Yeah.
Welcome, everyone. Thank you so much for coming to CPC today. I'll try and find my light here. So welcome to everyone who's here in person. Welcome to all of the applicants who have joined us online. Hopefully we'll have a great time, or maybe just a virtually great time. Here are the disclosures. Again, I will say for the second time, the instructions were unclear, so I put more than I needed to on there. So welcome today to Clinical Pathologic Conference here today on the 22nd of November. The case today, and we'll return to this in a few minutes, is the case of a 47-year-old man with depression who presents to the hospital after syncope. And our expert today is Dr. Alan Braverman, and we'll tell you a little bit more about him in a minute. So just a brief word on the history of CPC. Especially for those joining from elsewhere. So it's one of our most popular conferences. There are a lot of people here today. That has nothing to do with the Thai food that we serve on Fridays. And the idea is to watch a master clinician reason through a challenging case and help us all in our learning about how one of our mentors and inspirations walks through a medical case. It originally started at Harvard, where they took the concept of case reports from the legal field and then applied them to medicine. It then spread throughout the country, and it was brought to WashU in the early 20th century by our first chair of medicine, Dr. George Dock. And here he is looking like he's about to give some constructive feedback. So here today with us, a very kind face to replace the last one, is Dr. Alan Braverman. So to put a few of his resume virtues, though there's always much more to a person. He is the alumni endowed professor of cardiovascular diseases. He's a professor of medicine here in the Division of Cardiology. He is the director of the Marfan Syndrome and Aortopathy Center. He's the director of the Neerdorf Aortopathy. Goodness, I have an expert here. And master clinician in cardiology fellowship program. He completed his undergraduate and medical school studies at the University of Missouri, Kansas City, and his residency at Brigham and Women's Hospital and Harvard Medical School. And then he did a number of years of fellowship training, as well as some postgraduate training at Brigham and Women's, as well as Harvard. So I'll pass it.
As your partners told me, we often hide things and change things around. So it's probably not a 47-year-old male with depression that had syncope. It might be something totally different. But if it is this case, let's just think, what do you think about syncope? So first, syncope is transient loss of consciousness. And by definition, it's transient. So the person usually hits the ground or falls to the ground and then usually recovers and recovers quickly. And that's the definition. And usually it's because when you're supine, whatever happened to make you lose consciousness is rescued by the supine nature. So blood flow and blood pressure is usually restored. The most common cause for syncope is abrupt loss of circulation to the brain. So that is some malperfusion to the whole of the brain, not one side or the other. And it's usually just due to a drop in blood pressure. But it can cause severe injury. Our neuro ICU is filled with people who've had terrible trauma from syncope, falling down these stairs, crashing a motor vehicle, drowning, all sorts of terrible things, as opposed to a transient thing that just has a minor injury or no consequence. So you have to think about that when you're seeing people with severe injury. What was the underlying cause? So the most common cause for anybody in the room that's experienced syncope are benign things like reflex syncope. About 20% of us will have a syncopal event in our lifetime. And there's different peaks. In young, healthy people, it happens early in life, and it may be repetitive, usually from a reflex reaction. We call those neurocardiogenic, vasovagal, vasodepressor, where a reflex is stimulated. You lose blood tone, sometimes heart rate, and you collapse and then recover, and it's a recurrent event, or related to some reflex event like, bowel movements, things like that, fright, anger, upset, etc. In our cardiology clinic or coming to the emergency room with syncope is different, especially if you have underlying cardiovascular disease. If you have an underlying cardiovascular disease, and syncope can carry a much different connotation. They're less common in the overall spectrum, but they're more serious and life-threatening. So that's kind of the way you think about it. We talked about reflex syncope. Again, young people, common, recurrent, and people describe prodromes. How did you feel before it happened? So getting a careful history is very important. The person may not remember it, but you can ask witnesses, bystanders, people like that. You can get on the phone. What really happened? Tell me about what exactly happened. What did you witness about it? We think about orthostatic hypotension. This person has depression, so this person, that would be again in the differential, maybe it's a medicine or something like that. In older people, then falls and syncope more common because dysautonomia becomes much more common in old people. You don't think about that in young people so much. And then carotid sinus syncope, that's an older person's condition generally. Now, what's that differential from the cardiologic standpoint, from non-reflex? And the tricky thing is people can have underlying structural heart disease and still have reflex syncope. So again, you could have, a gene abnormality or moderate aortic stenosis or some condition, and you can still faint, at the site of blood or during phlebotomy or when the fellow's putting pressure on your groin during a cath or something like that. You can still faint, and it's not the heart, it's the reflex reaction. So some people have more than one thing. We think about fast heart rates, typically ventricular tachycardia, leading to syncope, being transient. This person has depression, could be on an antidepressant or something that could lengthen QT or be associated with some other long QT. So torsade comes into play in anybody, but in this person in particular. Bradycardia and conduction disease, not as common in a 47-year-old. It's more common in older people with transient syncope. And we used to have a lot of trouble diagnosing syncopal causes, coming up with an answer. So there was a lot of we don't know. But now we have things like recorders and loop recorders and implantable recorders and watches and home devices to try to capture in real time when infrequent syncopal events occur that help make the diagnosis more frequently than historical, especially with cardiac arrhythmia. In structural disease, usually an examination will help you hear. We hear a heart murmur, aortic stenosis, whatever the level it would be. Hypertrophic cardiomyopathy may present with syncope from an obstruction standpoint or a ventricular arrhythmia standpoint. And then rarer things related to tamponade. A congenital coronary anomaly can present with syncope. You can have a left coronary artery arising from the right coronary sinus, coursing through the great vessels and getting compressed, so having syncope during physical activity. Or then rare things, cardiac tumors and masses. PE can cause syncope because of abrupt lack of blood flow to the pulmonary circulation, as can pulmonary hypertension. And there's one disease on here that I know something about. Thank you. Aortic dissection. So I'm sure it will not be an aortic dissection presenting a syncope, but 9% of patients with type A dissection, a dissection involving the proximal aorta, have aortic dissection. And that's usually due to tamponade or a reflex reaction from the pain from that. And that's a poor prognostic indicator, syncope and aortic dissection. So non-syncopal causes of loss of consciousness or other things that I sure hope this person doesn't have, because I'm out of luck with these things. So is it a seizure? That's different. It lasts longer. People that have syncope that don't have brain trauma from the syncope wake up pretty quickly. So if there's a long period of unconsciousness, either there's been trauma to the brain from the syncope or it's something different, like a seizure or intoxication or cataplexy or narcolepsy or pseudoseizure. So I sure hope it's not pseudoseizure. Okay, now, how do you approach a person with syncope? Most important, like most things in medicine, is take a very careful history. What happened? Just listen for a few minutes and let the person explain what exactly happened. What was the prodrome? What was the circumstances? People that syncopize standing for a long time, like I'm going to do shortly, that could be reflex. Syncope while sitting, not so much. Syncope while supine is bad. Why would you pass out when you're already supine? That's usually an arrhythmia or something dangerous. If people have recurrent events again and again and again, it's usually reflex syncope. So think about that. And then what happened afterwards? After reflex, they can feel nauseated, maybe have, upset, sweaty, uncomfortable, feel kind of like in a fog for a while. Usually with a cardiogenic event, it's pretty quick, and then they recover quickly and are back to normal. Again, we talked about things that think about non-cardiac causes, like these sort of things, triggers, young people, no cardiac disease, and we think about things that worry us that it's a cardiogenic cause. Again, exercise-induced syncope, someone's playing basketball and hits the floor, usually bad. If they play the whole game and get on the bench, that could be different. Initial evaluation, pretty simple. Family history, does anything run your family? Sudden death, drownings, unexplained events. Always think, could that be cardiogenic? Do they have hypertrophic cardiomyopathy, long QT, brugada, arrhythmia, things like that? What medicines are you on? Can they cause orthostasis, long QT, et cetera? Careful physical exam for the pulses, orthostatic blood pressure, cardiac exam for murmurs of aortic stenosis, for hypertrophic cardiomyopathy, and usually simple labs, but you can include things like D-dimer and troponin and drug screen and then you look at the EKG, look at available rhythm strips. And then when you think of structural heart disease, you want to do an echocardiogram. But in general, that initial evaluation, just with that, you'll be diagnosing the patient correctly in about 60% of cases. You don't need extra tests to help understand what it is. My guess is the answer will not be in the initial stuff. So we'll have to probably do some other things that are tailored depending upon what you're thinking about. So that's really it. The last thing I wanted to say is I was very grateful for this slide that says you have 1,000 patients with syncope and the unknown was 34%. So I have a chance if it could be in that unknown category of saying I don't know. And that's about right a third of the time. But you can see how infrequently some of the other things really are in big case series. Okay. My kids always say, it's not fair, Dad, you love your work, because I do. So it's not really work. It's to love what you do. And also be a student forever. So today we'll all be students and we'll learn today like we do every day. Okay, that's my initial stuff.
Wonderful, thank you. You can keep that if you'd like to use the laser, and then I'll follow along with the computer laser for the listeners. But again, we'll just remind you all that we have the case of a 47-year-old man with depression presents to the hospital after syncope. We did not switch it up on Dr. Braverman. So I will begin with some bullet points on the HPI and then pause in case there are other questions before moving on to the rest of the history. But this is a patient who presents in September, not this September, but in a September after 2 syncopal episodes at work. He was seated at work and last remembers standing up before he found himself on the ground. He wasn't able to identify a clear precipitating factor, and he did not have any prodromal symptoms. He has approximately 1 week of shortness of breath that's increased from prior on exertion, and he has occasional palpitations. And in June, he remembers some ongoing dyspnea on exertion, and he and his family went on a hiking trip in July to Zion in Utah.
Okay, so first, he didn't feel well in June. So we're going fast forward 3 months. So 2 events separated by some time, seated, stood up, don't exactly know what happened and doesn't remember any prodrome. But before the event, he did have some symptoms of either cardiorespiratory origin, worsening shortness of breath with exertion, and he did have palpitations. So it makes you think, an underlying cardiovascular condition or a cardiovascular or an arrhythmia. But he wasn't normal in June. He had some dyspnea. And then he went hiking in Zion. Well, Zion has a lot of height, depending on which trail he went on. And you go in July, it's hot there. So we did a family vacation to Zion and all these beautiful places in southern Utah and hiked all these places. So you have to be in pretty good shape. And we don't have any information about what happened then, but he wasn't quite right in June. Thinking about hiking in Zion, that's not a high tick area for things like that, but because you're up pretty high and there's not a lot of bush and stuff like that. They're really trails. So probably didn't get bit by a tick up there. But so anyway, some prodrome of symptoms that make you think that you have an underlying problem that was developing beforehand that led to these syncopal events.
Mm-hmm. Of note, he does work at a news facility, and so he was heating lunch, and then he went to increase the volume on a police scanner, and then as he was standing up, he fell, and then was found, and people saw him fall, and then as they weren't really able to reach him yet before he was already waking up. And they don't remember any tick bites in Utah.
Okay, good.
Yeah. Any other questions based on the HPI right now that you'd like to know, or I can move to the rest of the medical
Well, here's
history.
the question. Well, I guess we'll hear some past history to know if he's just a healthy person or what the background is. But I'm suspicious of an underlying condition, though.
All right, so we'll move to more of the past medical history. So he does have a history of depression, and that is treated on fluoxetine 20 milligrams daily, and that's a stable medicine for him. He doesn't have any significant past medical history. And unfortunately, to your point on the initial workup, he is adopted, so he doesn't have any knowledge of his biological father's medical details. He knew of his mother, but wasn't aware of any diseases in her and no sudden cardiac death when asked. There aren't any known drug allergies, and he's neither smoked nor been exposed to smoke from tobacco. However, he does smoke marijuana as recently as the night before admission. There's no other recreational drug use.
Okay, so the past history, remarkable for no past history. Medications, just the fluoxetine, not a new medication, not one that you'd associate with syncope by itself, and nothing else that would raise a red flag here.
Right. So just going through a review of systems, he has no fever and chills. The only significant things that pop out on the review of system is he's short of breath on exertion. He does have palpitations, some of them with exertion. And he had loss of consciousness 2 times that we're aware of, and he has treated depression. But otherwise, he has no other symptoms as he presents to the ED after these events. He was brought in by EMS. Any additional thoughts or where you might be going at this point?
Well, something's wrong. He has dyspnea on exertion, which is not normal for a healthy 40-something-year-old without any reason for that. So is that an underlying cardiac problem? Did he have some form of a cardiomyopathy? Did he have some sort of a valvular problem that was congenital, like a bicuspid valve? Did he have hypertrophic cardiomyopathy that he's getting dyspneic on exertion now? Is he in some sort of arrhythmia? Or does he have a pulmonary process that's leading to the dyspnea upon exertion? Wouldn't associate with the palpitations so much. That would be a separate thing. Doesn't sound like an acute PE. Something's been going on for some time. So still thinking there's something underlying this, some either structural disease or some problem with the myocardium or pulmonary circuit. So next test would be a physical exam.
And we'll give it to you. So on the physical exam, the really notable things are there's a heart rate of 50 beats per minute, and they note the bradycardic rate when they examine the cardiovascular system. It is a regular rhythm, and there are no additional heart sounds or murmur that they notice. He did fall on his face, but they don't see an injury there. And while this blood pressure is abnormal, I'm just happy to get a blood pressure when I'm inpatient, so I did not make that red in color.
Okay, well, the blood pressure is elevated, so it's not normal. The heart rate is 50, which again, his definition is bradycardia, although you can be a healthy person and be 50 to 90 is really more of the typical as opposed to 100, but still a little bit low. Oxygen saturation is normal. He has a rhythm is regular and there's no abnormal sounds. We didn't get an orthostatic blood pressure, but he didn't start low. So everything else is just bradycardia is the first thing. So you say, oh, why would okay, let's say he has some primary arrhythmia. Well, we'll see that on an EKG if he has a primary arrhythmia. A heart rate of 50 won't cause dyspnea on exertion unless somebody's in something like a complete heart block, and they're stuck at 50. So they might be breathless because they can't enhance their cardiac output during exercise because their heart rate doesn't go up and the cardiac output doesn't go up. So that's it's be unlikely. So if that was complete heart block, why would a 46-year-old have complete heart block? He's not on any medicines to do it, unless he had some infiltrative disease. Sarcoid can cause heart block. See something like that in a young person, it has to present sometime. Lyme disease can cause heart block, but usually on presentation with acute Lyme. He didn't have any tick, he didn't have a rash, target lesion, things like that. Didn't have erythema chronicum migrans, but we have to talk about those things. So we'll see what happens on his EKG. So we want to see an EKG next, and then we want to see routine lab work. In someone that's dyspneic like this, you want to make sure they're not anemic, because that can cause dyspnea upon exertion. It wouldn't, again, make you have syncope. It wouldn't make you have palpitations. So we want to have a routine set of blood work, which is everything that includes the correct answer. That would be the routine blood work.
Wonderful. Okay. Well, I appreciate you saying routine blood work, because that's my next slide. And then right after that, we will go to the EKG. So.
Okay, so this is perfect, because if you say, well, how likely in somebody with syncope is a routine blood test going to show something abnormal? Not very common. So that's the usual. So expect to see something like this. The potassium's a little bit low. Don't have a good reason for that. But the rest is pretty good. It's probably not a fasting blood sugar of 134. Liver tests are normal. Proteins are normal. And CBC is normal.
Right. I'm going to bring up the EKG next, and I'm obscuring a little bit of the EKG because someone was kind of like me. I always carry a pen so I can annotate my books, and this person heartily annotated the bottom strips, so I'll obscure those for a moment.
Okay, so usually on the EKG, I like to see the interpretation. That's usually the most helpful part, and that's obscure. So I'll have to go from what we have. Anyway, so what you can see, so this is a 12-lead EKG, and what you can see is there's a heart block present. So let's see if I can get the laser on this thing.
If you want to point the laser up here,
okay.
I'll follow along with the other laser.
Okay, so it's at first you see there's not a P wave in front of every QRS. Well, the P waves before the QRS complex might be variable. That's the first thing you can see in the rhythm strip at the bottom here. But so we'll go to the QRS complexes next. So there's kind of a right bundle morphology rhythm for the ventricular rhythm. The heart rate again is about 50. Just kind of eyeballing it. It's pretty constant. You want to say, is it exactly constant? And then you see the P waves. There's more P waves in QRS. You say, where's the P wave? Well, there's one, but it's awfully close. Here's one that's not conducted. Here's one that's kind of fused. And it kind of looks like the P waves are going through at 100 beats per minute here. And you can see the PR interval here is a lot different than this one was. So this is probably complete heart block. Or there's some high-grade AV block with a 2-to-1 rhythm here. So it's probably complete heart block. The P waves don't look like they're manipulating the QRS complex. So yeah, and here's somebody that kind of marched those through for us. Now this actually looks like it's might be trying to conduct with it. You see how these P waves kind of might be associated. So sometimes it's not complete heart block, but there's AV dissociation, and sometimes it's right on track. We call that isorhythmic AV dissociation, where the rhythm is almost exactly the same. But if they ever associate with each other, the difference between the RR intervals will change. So in other words, because this looks like maybe this is sinus here, you see these P waves look like they're connected, and then this one's kind of fused. So you say, well, why is that? So there is AV block here and a right bundle branch block. So we're seeing conduction system disease. So now what are we thinking? Now we're thinking that this person's syncope could have been a more high-grade AV block. So it could have been a transient, more complete block where you had several P waves and the QRS didn't follow. And then all it takes is 3 or 4 seconds when you're standing without a QRS complex to faint. So that's what I'm concerned about. So this person, patients have syncope frequently, and there's a whole set of circumstances to say, well, who needs to be admitted to the hospital? Because, obviously you want to put people in that are at life-threatening problems, but you don't want to put everybody that has reflex syncope, vasodepressor syncope into a hospital. So this would say, yes, put me in the hospital, because this is an abnormal heart rhythm that could associate with significant consequence if syncope had happened again from a profound bradycardia.
And I'll point out that about an hour later, the telemetry changed somewhat. So they ran another EKG here. I'll just show that here briefly.
Perfect. So this is a nice example so again, the QRS complex didn't really change. So you're left with this sort of right bundle pattern here for the ventricular rhythm. It's a little slower, maybe about 40 beats per minute or so, something like that. And now you can see there looks like a P wave in front of all the QRS complexes. You don't see anything, deflecting the T wave probably. Sometimes you're fooled. It makes a little extra hump on here, but I don't think we're seeing that. This is probably sinus bradycardia, first-degree AV block, and a right bundle branch block in somebody that has. So this is somebody with, just like the history would be, intermittent heart block.
All right. So we'll translate now. We'll transition to additional diagnostics and what you might want first for this patient.
Okay, so is an EP consult on that? Is that possible?
Well, I can tell you what they say later, but I'd like to wait.
Well, okay, so I mean, I'm a general cardiologist, and I've been around long enough to know that here's the good news. There are a lot of people that can help understand this problem if the general person doesn't come up with all the answers, because this person has symptomatic conduction disease. So, but really it kind of understand, well, what do you think about? Why would this be the case? Could be underlying structural heart disease. In other words, some sort of problem in the myocardium itself that associates with heart block. Now, there's all sorts of conditions. More common ones would be sarcoidosis. Sarcoidosis can present with conduction system disease, usually complete heart block, but you get granulomatous disease in the conduction system. AV node has a predilection for that. And then the combination, then you say, well, who do you think about cardiac sarcoid in somebody? Well, they can present with heart failure, of course, if the myocardium is the dominant, but they can also present with one or more arrhythmias. And the combination of arrhythmias like heart block plus ventricular arrhythmias is like a classic. That's a sine qua non. So if you see that on somebody, you think about sarcoid. So that'd be in the differential. Transient heart block, medicine related, but this person's not on any medicines. You could imagine somebody on a beta blocker and a verapamil calcium blocker or something like that together, which we don't use that often to cause heart block. Underlying problems with infections can cause heart block. Those would be like Lyme disease. That's a classic presentation for heart block. That's usually transient, treated with, when you treat the acute Lyme disease, the heart block generally goes away in so many days. Many times you don't require a pacemaker because it goes away. So that would be in the differential diagnosis. Let's see, Chagas disease, he didn't really have any risk factors for that disease. Travel to Central and South America in particular, things like that. Those are some of the things I'd think about. In this person, and then, rare things would be combinations of myocardial disease and electrical diseases that are gene-based, usually associated with more left bundle branch block, things like that. And primary conduction system disease would be just uncommon in a 47-year-old. If this was a 75, 85, 95-year-old person, then you think about just primary conduction system disease by itself, leading to intermittent heart block. So here's a bunch of stuff you can do. Yeah, I'll take all of it.
All right.
No, seriously though. So we'll start with an echocardiogram because you do things in sequential order. So usually an echocardiogram first, and if it didn't show anything, then probably do a cardiac MRI next to see is there, can we see anything infiltrating the heart? You're helping me here by adding things, so this is great. The only thing not on here, oh no, there's infectious evaluation. So we didn't talk about endocarditis. Endocarditis can cause heart block, and no symptoms for that. No fevers, chills, sweats, things like that. No, elevated white count. So, gonna not put that on unless the echo shows something surprising. So I would, starting with these things, I would probably have done echo first, maybe a Lyme titer.
All right.
That'd probably be my first start.
Perfect. So the benefit to you is that I put the echo a little bit deeper in the information. So you're going to get some free info here when I click on cardiac evaluation. So the EKGs were as shown. They did a troponin trend in the emergency department that they stopped trending after 13. The NT-proBNP was 127, and then they did a lipid panel, which is as follows. And I will place the whole TTE impression up on the screen.
Okay, so the labs don't show anything of diagnostic importance. The echocardiogram is important as it's basically unremarkable. A little bit of altered relaxation might be difficult to measure that depending upon the rhythm the person's in. Lipomatous hypertrophy of the septum would be expected if the person, I don't remember what his weight was, but if the person had obesity, you might see that. In a thin person, you're like, what's that all about? Are you sure that's what that is?
The patient is overweight, yeah.
Okay.
All right, so we'll come back here. I'll show you, since you asked for everything, I will just show you the chest X-ray. I'll put it up here on the screen. And we have a radiologist with us, but I'll ask you to maybe make comments on this X-ray.
Okay. Well,
what I'm saying is I didn't ask the radiologist to read this chest X-ray.
No, I was thinking they're probably going to be, I should have said a CT scan or something, or an MRI, because you have a radiologist here, which, so the cardiac silhouette is pretty unremarkable. The aortic shadow is pretty good. I would wonder if there's a little hilar or something, if the hilum looks a little bit prominent over here, maybe a lymph node in the hilum or something. That might be interesting to see what the read was, thinking about the sarcoid diagnosis.
And right here, I'll tell you that the chest X-ray here was read as normal cardiomediastinal silhouette. The bilateral lungs are clear, no masses or focal consolidation, no pleural effusion or pneumothorax, and there was no comment made on the hilum.
Tyler, well, not every radiologist makes that diagnosis, so we'll see what the next tests show. It's probably not that. Okay, so what about the Lyme titers?
All right, so the Lyme titers. The ED infectious eval here just shows that he was COVID negative, and I will put in the additional infectious evaluation.
Okay. So again, no Lyme disease. Again, nothing in the clinical history would suggest clinically that he would have that. These other viruses, I'm not really sure why, how that would associate with this presentation. And tuberculosis, boy, if this was a case of tuberculosis, this would be CPC worthy. That would be pretty amazing. So yeah, so none of these would be surprising to be normal, Carl.
All right. And I'll point out, I guess the physicians in the emergency department on the floors found this patient to be very trustworthy. So they did not get a urine drug screen, but they did get these urine studies, which I'm not sure will illuminate the case.
Not really. 1+ blood, but no red cells probably. So yeah, none of those. So that doesn't really mean much. Again, looking at this thing, like, why does this young person have, intermittent heart block? I probably would do, even though again, nothing symptomatic, but what is his breathlessness could be from the, chronotropic incompetence, maybe he didn't get his heart rate up with exercise. I mean, it has to be a reason for that. The echo didn't show a structural abnormality. The pro-BNP didn't show elevated cardiac pressures or anything like that. I would, before I would get an EP person, I would probably do a CMR just to say, is there any infiltrative cardiomyopathy here? That because the tests have not, none of the tests exclude something like an infiltrative cardiomyopathy like sarcoid. Again, we don't have any clues for that. Sarcoid more typically presents with more widespread manifestations with lymphadenopathy. So we haven't seen that on a chest X-ray. We didn't see, but you can have primary cardiac sarcoids, and he's the right age for it. So I would probably do that. And if you say we didn't get one, then I'm out of luck. Then I'll go to my next step.
All right. Well, we brought a radiologist for a reason. So we have Dr. Jim Raptis from the Department of Radiology here with us, and a cardiac MRI with and without contrast was ordered. And I will bring that up on the screen.
These are some selected images from the cardiac MR. They're all the late gadolinium enhanced images. So we're looking for infiltrative disease, as Dr. Braverman had mentioned there. Areas of enhancement within that myocardium are considered abnormal. And you can see here that as we're moving from the base of the ventricle on the top all the way to the apex, we have areas of subepicardial and mid-myocardial enhancement in a non-vascular distribution. Those are our short axis images. So we have some in the septum, we have some in the anterior wall, we have some in the inferior lateral wall, and then the corresponding 4-chamber view and 2-chamber view shows similar findings.
You want to point to it, Jim?
So these are the areas of subepicardial enhancement you're seeing here. Additional area here. Again, here in the anterior wall, and then here we have it laterally and inferiorly. And then our corresponding 4-chamber view, you can see some more kind of patchy enhancement here, mid-myocardial. And this is a 2-chamber long axis showing similar findings. So this would be suggestive of infiltrative disease.
What's the last thing you said?
It would be suggestive of some infiltrative disease or scarring.
Okay, so the MRI, again, so we don't see any signs of myocarditis on this study. Is that fair? Does the sequences evaluate for that possibility?
So
for acute myocarditis?
These corresponding images, there's overlap in imaging findings. They could also represent the myocarditis as well.
So many times, so first, it's an abnormal study, that's for sure. And interestingly, there's a big discordance between the findings on the MRI and really a normal echocardiogram. In other words, we don't see, wall motion abnormalities. We don't see severe cardiomyopathy. We don't see pericardial disease. We don't see any other features that would say, oh, this is a raging myocarditis that also has heart block or something like that. This is more something that's been going on for a while. We don't know exactly how long. And then certain types of infiltrative processes have more characteristic localizations. like mid and subendocardial, which I think is more consistent with sarcoidosis. But maybe, Jim, you could tell us what's the differential when you see this?
Yeah, so the differential that I would include on this would be sarcoid, as you said, subendocardial, mid myocardial enhancement, and a non-vascular territory sarcoid be something we immediately think of. You brought up myocarditis. So certainly in the acute phase of myocarditis, we'd expect to have some T2 signal abnormality, which I'm not showing you here, which would be suggestive of edema. But this could certainly be the residual of myocarditis with some old scarring. And that would be kind of the differential I'd have with no provided history.
Yeah.
And going back to that chest X-ray, the MR images didn't show any lymphadenopathy.
Didn't show any adenopathy. Okay. Well, so now we're stuck or left with a very abnormal cardiac MRI study in somebody with intermittent heart block, and you say, you know, what do you think's next?
They did get one more imaging study that it took several days to schedule.
Well, I was going to say is, well, because you say, well, you know, what else could this be? Well, first, troponins are normal. And when you think about acute myocarditis, usually troponins are elevated. Usually you have abnormal EKG. Many times people have chest symptoms that, you know, like a myocardial infarction. Some people have symptoms like pericarditis or epicarditis, pleurisy, those sort of symptoms. So nothing like that. And no prodrome of viral illness or anything like that. Now, when you see this pattern in somebody that has, you know, conduction system disease, you want to say, okay, is this old and burnt out and left with this, or is this acute? In acute sarcoidosis, you have inflammation and abnormal PET studies. So usually the next step would be a PET CT scan to see first, is this light up consistent in a pattern with active sarcoidosis? If this is cardiac sarcoidosis, we want to treat this. We want to treat this aggressively with glucocorticoids and then other agents to suppress this so it doesn't lead to progressive cardiomyopathy. Right now, the LV function is preserved. We have no history of ventricular tachycardia. So this is active sarcoidosis with this sort of presentation. You wonder, is this person going to need a pacemaker? Or are they going to have features that would make you think about a defibrillator? Usually that's with ventricular arrhythmias and sarcoidosis. So I'd probably do a PET CT scan next. Endomyocardial biopsy in the setting of sarcoidosis is hit or miss, because just like you can see here, it can be patchy. So you can biopsy the right ventricle. We don't usually biopsy the left ventricle, and it can be normal, yet they have sarcoidosis. You just didn't see a granuloma. So that can be part of the situation, but a normal biopsy doesn't exclude cardiac sarcoid. So that's still the thing I'm most concerned about, and I'd probably do a PET CT next. Okay, so very abnormal PET CT scan. Hopefully, Jim, we're going to tell us more about that.
I don't routinely read these images, but I don't think it requires a radiologist to interpret this one. As you said, very abnormal. We have FDG uptake all throughout the myocardium, more extensive than what we're actually seeing on the cardiac MR. Also note here, there's some uptake in the right ventricular free wall, which if you go back to the MR, you can probably correlate to some subtle delayed contrast enhancement there, but it is right here where you see a little bit of that. So kind of confirming the findings of the MR, we have some grossly abnormal uptake in the myocardium without giving you the diagnosis I'm sure you've arrived at already.
Okay. And they did obtain pathology, and to Dr. Braverman's point, they did get deep biopsies, but they can be patchy and subjected to sampling. So they require Dr. Braverman's clinical correlation. So any concluding thoughts about this case?
Okay, so was that the answer? Was it cardiac sarcoidosis?
Yes.
Okay, well, I mean, it's supposed to be that, but you never know. Well, okay, so a few things. First, I mean, I wish my kids were here because I got something right, and they would say, that's the first thing. But I mean, this is not the usual situation for syncope. That's the first thing. So this would be, you know, on the list, but a rare cause of syncope. So what do we do today? We talked about all the things that syncope usually is, and then how do you think about them? You know, getting a history, et cetera. This was instructive because it wasn't a once off. He had symptoms going on for some time. So that means he probably was in this abnormal heart rhythm for some time. And you can see how intermittent it was. I mean, what if you caught the guy with a 12 lead and he just had a sinus rhythm with the right bundle? You're like, well, what is that? You know, why are you having syncope? Is it an intermittent arrhythmia? Because he did have that. And so sometimes he went so slowly that he, you know, probably had syncope. Now, he could still have VT. He could have had VT making him have syncope. We don't know that. In the days he was in the hospital, he was on continuous telemetry. And if he had NSVT, he'd get a defibrillator for sure. Now, the question would be is, obviously the next. So we went through the differential. What triggered this thought? Well, the abnormal heart rhythm. It's just not common to have conduction system disease in young people. So you say, what would that be? And unfortunately, I exhausted my differential, which was, infection like Lyme or endocarditis, and then infiltrative diseases. And I'm sure there's a whole list of other things. If you had EP person, they would have gone through a much more eloquent description of all the other things it could have been. But then the echo being normal doesn't dissuade you from saying, let's do a test that now we can look and really see what's going on inside the muscle. And that CMR was super helpful here. And of course, we have great radiologists that can provide what does it look like and what is the usual thing. So that was very helpful. We have great cardiac radiologists. And then we can do a test that shows it's active, which is a cardiac PET, and we have great people reading that. So that's what it is. And then, as I said, let's do a biopsy to prove it. Well, that wasn't really necessary because it's not that helpful. Nothing happened, thank goodness. But a normal biopsy doesn't exclude it. So that's the lesson here. And that's everybody teaches that. And now you see it in real life, that's how it is. Even though it's pretty involved, you still didn't catch it. Now you have to treat it. So usually your cardiologists treat this? Of course we do, but usually we have rheumatologists or pulmonologists. We have a very active pulmonary service that's involved, and pulse steroids, that's the usual treatment. So yeah, let's see what happened.
Yeah, just to point out that he did have 2 more events of syncope while he was inpatient waiting for the PET CT, and then was taken to the CCU for closer monitoring. He began a course of pulse dose steroids after the diagnosis was made. He was referred to 2 of our pulmonologists who specialize in sarcoid. Was treated on a steroid treatment and methotrexate and folic acid. He's done well, but this last June, he had some more increase in the myocardium and the FDG avid increase. So he repeated a steroid course, and there's consideration to escalate to infliximab. And just pointing out that we don't yet have an identified antigen that spurs this macrophage aggregation that forms the non-caseating granulomas. Caseating meaning cheesy, so you can now call your father's sense of humor caseating. Hopefully not granulomatous, but cardiac sarcoidosis may present exactly like Dr. Braverman said. And as he pointed out, the biopsy has specificity if you catch it, but it's quite literally hit or miss. And it does not spontaneously remit as often as maybe some other sarcoid manifestations. And thus, there is some argument that you should use steroid-sparing immunosuppression earlier in the course. So they're considering infliximab for this patient. So thank you so much, Dr. Braverman. Congratulations.
Thank you.
Great, good job.